bugs and bugs. We keep on talking about bugs all the time, bacteria, fungus, virus. So what is it all about? Why are we so much bothered about bugs? We are doctors, we are treating patients. It should be all about us. Why are the bugs important? Well, I'll tell you why the bugs are important. The bugs are important because we are basically living in their world. We human beings, we have come in this world 1,000, maybe 10,000, 100,000 years after the bacteria or the fungus. And we will be extremely for this world, and they will outlast us even 100,000 years after the last human being is dead. So it is actually their world that we are inhabiting. So we have to take care of them. So we had a lot of worries about bacteria in the past years, and now time is changing. Bacteria is already there. Now we have a lot of headache that is called fungus. And Candida is the main headache that we have when it comes to fungus. So my presentation is titled Secret to Success. It's not actually a secret to success. This should more be like an update. What are the new updates in the therapy area of invasive fungal infections, especially invasive Candida infections? So first of all, I would like to thank all of you for giving me a second chance of coming here and speaking. I came here in last year June, had a speech on diabetic foot infections, and this is my second lecture. It was a great experience that time, and it's a great experience this time again. So thank you very much. Now let's go back to our case, the case that was shown by Dr. Tanwar. So we have a 65-year-old patient, diabetic, admitted in the ICU for 7 days, post-intestinal dissection anastomosis, and has developed high-grade fever with neutropenia, no specific symptoms of any organ-specific infection, and high pulse rate, low blood pressure, and culture report is pending. So according to the risk factors shown by Dr. Malhotra previously, let me just take all of you back to the case. Let's highlight, let's focus. 65 years old, patient is old, number one. Number two, diabetic, second risk factor. Number three is admitted in the ICU for 7 days, third risk factor. Then we have post-intestinal dissection anastomosis, that is a major abdominal surgery, number four. And obviously, as she has a gut resection anastomosis, she must have a lot of cross-spectrum antibiotics. So that makes it 5. Then she has high-grade fever, neutropenia, 6, 7, and then no specific symptoms and impending shock. So this patient, in a small statement, has 8 risk factors for developing Candida infection. So what will you do? You need to treat that patient. What is the agent, what is the antifungal agent that you will choose to treat this patient? You're confused. You don't know whether it is fungal or bacterial or viral. You don't have culture report. You don't know that is it surely Candida or something else like Aspergillus or something. You don't know whether it is albicans or non-albicans. You don't know whether it is just colonization or infection. And finally, what you don't know is you don't know whether to treat this patient or wait for some time to get the culture. But I'll tell you, the answer to this has been laid out by Dr. Malhotra very clearly. The message is treat it hard and treat it fast. So it should not delay. So this question is out of the book, and all these are still in your head. And now comes an added question: which drug to use? You have 3 options: the polines, which are the amphotericin B group, and then we have the triazoles, and then you have the echinocandidates. Which drug will you use? You're totally confused. So let me go back to what can be done. The message is there: hit it early, hit it right, hit it hard. Start antifungals empirically, and especially follow the guidelines. Now let's go back to the guidelines. Now, considering this case, let us discuss 3 questions. So through these 3 questions, we will try to focus on which is the drug of choice that can be used in this case. So first question, which is very common: what is the role of fluconazole today? Fluconazole, as all of you know, it has been the gold standard for so many years. Fluconazole has saved so many patients with Candida. But what is the role of fluconazole today? Should it be preferred in sensitive Candida albicans, in moderate to severe Candida patients in the ICU? Let's go back to the IDSA 2009 guidelines. IDSA in 2009 laid out very straightly: if it's a non-neutropenic adult, you can use fluconazole as a primary therapy, but please remember the dose. It's 800 milligram loading dose followed by 400 milligram daily. Not 400 or 600 loading dose, 800 loading dose. Or an echinocandidates as a primary therapy. And as a secondary therapy, liposomal amphotericin B or voriconazole. But if it is a neutropenic patient, which is very common in case of Candida, there is no role of fluconazole as a primary therapy. It is only an echinocantrine. As an alternative therapy, you can look at fluconazole or voriconazole or maybe amphotericin B. But as a primary therapy option, fluconazole is limited only in case of non-neutropenic adults having invasive Candida infection, according to 2009 IDS guideline. So, in the same article, it has been mentioned that data from the randomized study suggests that an echinocandrin may be superior to fluconazole as a primary therapy for candidemia. And this statement has been made with reference to an article which is the Annette Siriboli et al. Study published in New England Journal of Medicine in 2007. So let's go back to that article. It is from New England Journal of Medicine 2007 by Annette Siriboli et al. And it says, anibulafungin compared with fluconazole for treatment of candidemia and other forms of invasive candidiasis caused by Candida albicans. It's a multivariate analysis. It's a post hoc analysis of the original article. So what is special about this post hoc analysis? So first let me tell you that all the specimens that were taken for this post hoc analysis, may it be in the fluconazole arm, may it be in the anibulafungin arm, all the specimens were sensitive to both the study drugs. So some of the specimens in the anibulafungin arm may not be sensitive to fluconazole. That may be the cause of treatment difference. That's not it. All the specimens were sensitive to both the drugs. So what were the results? 245, the total number of patients were 245 that were tested, and at the end point of IV therapy, the success rate difference was a drastic 16%, with a 76% success rate with anibulafungin and just 60% with fluconazole. So a wide gap of 16% success rate difference with anibulafungin compared to fluconazole in case of adult patients with invasive candidiasis. Now, efficacy in species-wise distribution, we don't have the actual species-wise distribution, but we have albicans versus non-albicans. In the albicans group, the anibulafungin had 81.1%, that is 81.1% efficacy, whereas fluconazole had only 62% efficacy. In the non-albicans group, 71.1% for anibulafungin compared to only 60% for fluconazole. So anibulafungin performed better in both Candida albicans and non-albicans Candida. Now coming to the median time taken for the patients to get negative blood culture, you can see here in the anibulafungin arm, the median time for negative blood culture was 2 days, whereas in fluconazole arm it was about 5 days. So obviously the median time to achieve negative blood culture was also very much significantly better in anibulafungin arm compared to the fluconazole arm. The Kaplan-Meier survival analysis, again you can see anibulafungin had a better survival rate compared to fluconazole, 23% mortality with anibulafungin compared to 31% with fluconazole. Now, the conclusion, the summary of the article is that anibulafungin was more effective than fluconazole with high efficacy and lower MIC rates throughout species, and similar in safety, but anibulafungin requires no dose adjustment for any kind of impairment, and again more rapid clearance of positive blood cultures and significantly fewer persistent infections with anibulafungin. So that is with fluconazole, our first question. Now let's go back to the second question. Now the second question will obviously be amphotericin B. Fluconazole, we have understood that okay fine, IDSS says for non-neutropenic patients you can use fluconazole, but still again anibulafungin perform better than fluconazole. Now let's get back to amphotericin B. What is the place of therapy of amphotericin B for Candida nowadays clinical practice? So some issues with amphotericin B and azoles. Amphotericin B, there is a question mark whether it is the agent of choice for invasive Candida patients in ICU or not. And again, toxicity is a major concern with amphotericin B. You have nephrotoxicity, infusion-related toxicity, hypokalemia, hypomagnesemia, and LFT abnormalities, which are very common with amphotericin B. Again, toxicity limits its efficacy, and at times there is a huge lack of efficacy, which is suggested by a 40% mortality throughout different studies with amphotericin B in invasive Candida infection patients. So if it is the gold standard therapy for candida, it should not have a 40% mortality. With azoles, the problem is that they are well tolerated with very good safety profile, but they are contraindicated in hepatic failure. And there's some issues with resistance. For fluconazole, it is Candida glabrata, Candida krusei. It is intrinsically resistant to azoles. And for voriconazole, there's a cross resistance for Candida glabrata. So in case of these isolates, which are now pretty common, as said by Dr. Tanwar and Dr. Malhotra, you have to think twice before using azoles. So we talk about, okay, fine, amphotericin B is nephrotoxic, but the newer formulations, the liposomal amphotericin B, the lipid complex amphotericin B, they are less nephrotoxic. So let's have a look. These are 3 studies. This is with aspergillus. Amphotericin B deoxycholin had a 30% rate of nephrotoxicity, that is patients who got creatinine levels more than 2.5. Again, coming back to Candida, in the study of neutropenia, patients with neutropenia, you can see amphotericin B deoxycholin had almost 30%, it is about 27 to 28% patients who got a creatinine level greater than 3, and amphotericin B lipid complex had around 70 to 80% patients who got creatinine level greater than 3 at the end of therapy. Again, another group of patients with neutropenia, amphotericin B lipid complex, they had about 20% of patients having creatinine greater than 2.5, and other lipid formations, again it was about 10 to 12%. So I would like to ask one question to all of you. You are selecting a drug for your patient. Nephrotoxicity is an issue for you. So in case of amphotericin B deoxycholin, which has about 30% rate of nephrotoxicity, and amphotericin B lipid complex, which has about 20% rate of nephrotoxicity, and liposomal amphotericin B, which is also quite similar, my question to you would be, would you prefer using liposomal amphotericin B or amphotericin B lipid complex with a view that it is less nephrotoxic? Well, it is less nephrotoxic compared to deoxycholin, but is it actually less nephrotoxic? That is the question. And the answer to that is obviously no. So, another issue that comes up with amphotericin B is that it is economic. People keep on talking that, okay, gynocytes are very costly, amphotericin is far economic, so amphotericin B is the drug to go with. Now, let us go back to the clinical infections. This is a 2002 journal, and it was mentioned that for the antifungal treatment with IEP drugs, the study shows that amulafungin is cost effective versus fluconazole, amphotericin B and caspofungin, depending upon the applicable cost effectiveness thresholds. And again, conventional amphotericin B induced a lot of renal toxicity and is associated with increasing mortality rates, which further increases the length of hospital stay and also increases the cost of hospitalization. So when you are talking about the price of amphotericin B, you should not consider the unit vial price of amphotericin B. You have to keep into mind everything. The patient might get nephrotoxicity, for that he might require dialysis, for that he might end up requiring a renal transplant. The length of hospital stay will be high. The patient might be staying for a longer time in the ICU. So you have to add up all the costs. So the total cost of hospitalization becomes higher in patients having amphotericin B. Now, going back to the IDSA guideline, as I showed all of you before, in the non-neutropenic group, amphotericin B doesn't have a role as of primary therapy, and in the neutropenic group again, amphotericin B is there. A liposomal formulation of amphotericin B can be used as a neutropenic for neutropenic patients, but you have to remember that there are negative recommendations in recent European guidelines, like this one. This is a European expert opinion on the management of invasive candidiasis in adults, and it says very clearly that overall there was no consensus on the most effective antifungal strategy, but there was an obvious swing away from amphotericin B because of drug-related toxicity. So it says clearly that amphotericin B, our focus is now shifting from quite away from amphotericin B. So let us focus on a new update which has come up in August 2012. It's called the ESCMID guideline, that is European Society of Clinical Microbiology and Infectious Diseases. And and they have laid out these guidelines for management of candida albicans in especially non-neutropenic adults. So first of all, they have mentioned guidelines for prophylaxis. As Dr. Malhotra said, there are certain guidelines of prophylaxis for different conditions. This is for mainly ICU patients with unknown fevers whose diagnosis is not confirmed. So for them, what will you use as a prophylactic agent? There are two criteria. Number one, to resolve fever, your intention is very important here. If you are looking just to resolve fever, your drug of choice will be fluconazole 800 mg per day, and patients persistently febrile without microbiological evidence to reduce overall mortality, you should use a fluconazole or a echinocandrin. And again, as said by Dr. Malhotra, if the patient is moderate to severely ill, if the patient has a history of prior azole exposure, you better not think about fluconazole in this case as well. Now, coming to therapy options, these are the recommendations on initial targeted treatment of candidemia and invasive candidiasis in adult patients. This, mind you, this is not only for targeted treatment, this is also for empiric treatment as well. So they have two classifications, one is prophylaxis, one is targeted, and involves empirical as well. So here they have laid out 3 drugs with a strength of recommendation A, and the 3 drugs were amulafungin, caspofungin, and micafungin. The 3 echinocandins. They had strength of recommendation A, and they had literature support of 1. So they are the best recommended agents. Again, among them, amulafungin is placed at first place. Why? Why is that? Why is amulafungin at first place? Well, because it is mentioned in this article only that in case of other echinocandins, caspo and micafungin, in their head-to-head clinical efficacy trials, that is phase 3 trials, they were compared with the drug which is amphotericin B. And the end result were, they were not reported to be significantly superior to amphotericin B. They were reported to be non-inferior to amphotericin B, but with a better safety profile. But in case of amulafungin, it was compared with the standard therapy option, which was fluconazole, and it not only got a better safety profile, but as I showed you, it had a 16% overall success rate difference. So amulafungin was given first preference among all the echinocandins. Then again, liposomal amphotericin B, it has a strength of recommendation B, voriconazole B, fluconazole has a strength of recommendation C, which is very important. Then again, amphotericin B lipid complex has C, and posaconazole gets D recommendation, which is against its use. So key points is that candida isolation from respiratory secretion alone never prompt treatment, because respiratory secretions candida is most of the time, 99% of times, it is commensal. Candida pneumonia is very, very rare. So microbiological evidence, as said by Dr. Kanwar, is not enough. You have to go for histopathology. Again, for targeted initial treatment of candidemia, echinocandins are strongly recommended. Liposomal amphotericin B and voriconazole supported with moderate strength, while fluconazole is supported with marginal strength of recommendation. While all echinocandins trials proved statistically non-inferior to comparative drug, amulafungin was found to be superior to fluconazole. Amphotericin B deoxycholic receives a D recommendation, which is against its use, similar to posaconazole. Fluconazole had a C recommendation, which again warrants its use as therapy option for candida. So this is about the ESC MIND guideline. Now let us come to our final question of the day, the third question. This is an article from India by Dr. P.K. Mukherjee et al. And the title is, echinocandins, are they all the same? Why is this question coming? Because in the IDSA guideline, it is mentioned an echinocandrin. They have never mentioned caspofungin or micafungin or amulafungin. Many people throughout the world used to believe that all 3 echinocandins are same because they have almost similar kind of a mechanism of action. All of them are non-cooperating inhibitors of 1,3-beta-glucan synthase enzyme. 1,3-beta-glucan is an essential component of the fungal cell wall, and without it the fungus cannot grow. So echinocandins basically work at that point. All of them have a similar kind of mechanism of action. But the question comes, are they all the same? When you are choosing your echinocandins, you have to keep this question in mind. So let us go back to some data. Mind you, they don't have any head-to-head phase 3 trial yet. There is no trial throughout the world which shows efficacy of Angular compared to caspofungin or caspofungin compared to micafungin or micafungin compared to angular. But there are data which can be extrapolated and we can come to some conclusions. So let us go back to some data. First of all, let us look at the half-life of the three echinogamrids. These are the beta half-lives. Angular has a half-life of 26.5 hours compared to 14 to 17 hours for caspo and 9 to 11 hours for micafungin. And what does it mean? It means that time to achieve steady state, when the drug is given to a patient, it must achieve a steady state to kill your fungus. So the time to achieve the state is different for all three echinogamrids. In case of caspofungin, if it is given through a loading dose, it takes about 5 days. And with no loading dose, it takes about 12 to 14 days to achieve steady state in the blood. In case of micafungin, 85% of the Cmax is achieved by the third day only. And in case of angular, obviously you are giving a loading dose and the steady state is achieved within first day of therapy. So in case of half-life and steady state achievement, angular fares better compared to other two echinogamrids. Now going to the volume of distribution, we are talking here about systemic candidiasis, especially invasive candidiasis, which is a bloodstream infection. So volume of distribution is very important. The drug should be distributed throughout the body well to act. And now coming back again, caspofungin has a volume of distribution of about 8 to 10 liters, micafungin 27 liters, and angular has a volume of distribution which is about 30 to 50 liters. So again, pharmacologically, angular is a better drug compared to caspo and micafungin. This is about the blood levels of angular. As Dr. Malhotra said, the problem with Candida parapsilosis is that it has a very high MIC range. And according to the CDC guideline, which came out earlier in the 2004-5, it said that if any drug has a MIC greater than 2 for any echinogambrin, you have to consider that to be sensitive. You have to consider that as resistant. But now the criteria have changed. So now let's take a look at the blood levels of angular. With the 200 milligram loading dose and 100 milligram maintenance dose, you see this is the blood level of angular that is maintained throughout. Here, Candida albicans and Candida glabrata has a MIC 90 of 0.12 micrograms. Candida tropicalis 0.06. Candida parapsilosis has a MIC of 2 for angular. But with this dosing schedule, the MIC of angular the Cmax of angular always remains above the MIC of all kind of Candida isolates. So most of the times you are supposed to get treatment success with angular with any of the Candida isolates. Now another slide, we will look into the pharmacology, that is the pharmacokinetic graph of angular in case of various patients. First, let us look at patients with hepatic impairments. You can see patients who are controlled with mild hepatic impairment, moderate hepatic impairment, and severe hepatic impairment. The pharmacokinetic graph is not changed at all. It's almost similar. In case of renal impairment, we get a similar kind of results. So no change in pharmacokinetic graphs. So there's no change in the behavior of the drug. So you need not make any dose adjustments in case of patients with mild to moderate hepatic or renal impairment when you're considering angular. But that is not the fact with other agents. You have to consider dose changes. So that is another advantage with angular. Now that's about it. So before I conclude my session, I will say one more thing. I'll just take 2 more minutes of all of you. That is, we have seen a few guidelines on treatment. Now there's another thing that is very important that is coming up and people throughout the world are talking about it, and that is de-escalation. Now we have talked a lot about de-escalation in case of bacterial infections, the role of procalcitonin and all that. But in case of fungal infection, we don't have any procalcitonin. So how can we de-escalate? What is the importance of de-escalation? De-escalation helps you to prevent resistance in case of future patients. And de-escalation also, it has been shown in the study that patients in whom de-escalation strategies have been taken up had a lesser mortality compared to similar patients who had not been considered for a de-escalation and continued the same antibiotic. So de-escalation is very important. In case of fungal infections, you're starting your patient, suppose with an echinocandins, which is a broad spectrum antifungal, and after say 7 days, the patient is improving, the patient is out of shock, the patient is better now, fever is down, counts are becoming normal, and you have a positive blood culture showing sensitivity to fluconazole. Go back to fluconazole. That is your de-escalation. But if you don't have a positive blood culture, there's no role of de-escalation. You have to continue what you're doing. So that's about de-escalation, and when using an anular fungin, keep all these things in mind, and the dose recommended is 200 milligram loading followed by 100 milligram every day, and you should continue therapy for 14 days from the last negative blood culture. So that's it. Thank you very much, and now I invite the forum. Feel free to shoot me your questions.